Nobody? Okay, all right. No announcements. Let's continue. Um, our secretary's okay, so our secretary stepped out. So I'm gonna go ahead and give the meeting minutes. I'm gonna give the meeting minutes from the last meeting. We had a meeting at Mayo Clinic. It was the lovely, lovely medical errors for 2 hours. It was presented by Linda Valdez. Yes, pretty much it. All right, new business. So Roche has graciously always agreed to sponsor this meeting. A big thank you goes out to Roche for supporting JAM every year. We really thank you. All right. Any questions, concerns before I start? You know how I am, straightforward. All right, perfect. So we're going to start with our first presenter. Um, the title of the presentation is called Surprise Souvenir Fever in the Returning Traveler. This will be given by Dr. Juliana Sobczak. Dr. Juliana Sobczak is a board-certified anatomic, clinical, and medical microbiology pathologist based in Jacksonville, Florida. She currently serves as an APCP pathologist with Southeast Pathology Associates at Baptist Medical Center and HCA Healthcare at Putnam Community Hospital. Dr. Sobczak completed her medical microbiology fellowship at ARUP Laboratories and the University of Utah. She performed her residency in anatomic pathology and laboratory medicine at the University of California, San Diego, after earning her Doctor of Medicine from the Medical University of South Carolina. Outside the hospital, she enjoys exercising with her 2 dogs and anything water sports with her husband. Round of applause for Dr. Sobczak.
Did I do something wrong? Oh, yeah. Yeah, there we go. Okay, perfect. And the mic's on? Yeah. Okay. Cool. Thank you very much, and thank you for having me. So I will be going over a case study or case report of a surprise souvenir, fever in the returning traveler. So I have no disclosures, and so we'll jump right into the pertinent clinical history. So this is a 48-year-old gentleman who presented with no significant past medical history. He presented to the Baptist ED with 3 weeks of afternoon headaches and fevers that improved with an antipyretic, but they kept on recurring and coming back. So of note, he had recent travel history to France. That's where he most recently came back from. But he was born in Cameroon and was visiting there approximately 6 months prior. Wait, to the right. Wait, to the left, to the right. There we go. There we go. I swear I turned all the way to the left. Okay, so he has no fever or headache in the morning. He denies any rashes, diarrhea, vomiting, cough, dysuria. And then a little tidbit that I left out. While last visiting Cameroon, he was diagnosed and hospitalized with malaria, and there he received full treatment course, resolved, and now he subsequently, when he came home, is having all these issues the past 3 weeks. So his pertinent physical exam and labs, his vitals in the ED, he was febrile to 102.6, his a little bit tachycardic, his heart rate was 110. And then some pertinent labs, his white blood cell count was within normal limits. Hemoglobin was low at 9. MCV, fine, 84. And then platelets were fine, but large platelets were noted. Some additional labs, his sodium was low, glucose was 116, and lactic acid was within normal limits. And so he was influenza, RSV, and COVID negative. So the ED physician orders the peripheral smear, and so it gets screened by the technologist, and this is what they see. So I'll let you guys, think. I'll show you a few more. Another one. Okay, and a few more. Okay, So what's your guys' diagnosis? Okay, what species of malaria? Any other thoughts? Huh? So why do you say Vivax? Zooites, so that in the liver stage. And so that's called like a recurrence if you don't properly treat, so that's true. Why do you say falciparum? Where? And these ones? Oh, like those ones, yeah. So those are ring, yeah, that's okay. So now, oh, I wish I could skip to show. Oh, so I'll tell you now that the rapid antigen test is the control is positive and the T2 band is positive. So that's ruling out falciparum. Okay. Okay. So okay, let's show this. This is what the rapid antigen test showed, which we do have we run at Baptist. Okay, so it was sent out to whatever Florida Department of Health, and it was confirmed as Plasmodium malariae. And so all, and I'll kind of touch on this a little bit, all of the plasmodiums can like have recrudescence, which is kind of what this case was, which was recrudescence is not the same as when you think of ovalian vivax as a recurrence. Recrudescence is most likely you knocked down the parasite load low enough to be undetected. And it was kind of at a low level festering for a while, and then it came back. And malaria, Plasmodium malaria is classically known for having recrudescence, but all four of them can. Okay, so kind of our differential diagnosis, we touched on all of them, basically. So all the four known human Plasmodium species are falciparum, vivax, ovale, and malaria. And then Babesia could also fall into this category. Those would be extracellular on the peripheral blood smear, and then zoonotic Plasmodium less likely. And then I also did think, kind of with fevers, you could, and like the travel to sub-Saharan African countries, you could think of the trypanosomes, like the sleeping sickness, Brugia. And actually, one of them can present like months after the initial inciting bite. But that one would be really cool if we saw that one. So we will go look at that. We'll kind of go over like why diagnostically it was malaria. So first thing when I'm looking at the peripheral smear, screening it, one I'm looking, oh, do I see anything? And when I see something, is it intracellular or extracellular to the red cell? So here, obviously, it's intracellular, so that takes away Babesia. And then second, I look at what's the size of the red blood cell. Sorry, what was that? Yep. So all of these ones are smaller. You look how it compares. And so the malaria is infecting the microcytes. And you look at the surrounding red blood cells, and they're all smaller. And then what the definition of a microcyte is the loss of that central pallor. So, here you see the central pallor, and all of those infected microcytes, you don't see that. So that's another big clue for malaria. And then, then next I look at the trophozoites forms, which is what these are all different trophozoites. So, classically falciparum, you think they're like the delicate, dainty, ring forms. And so you can see those in malaria as well, but classically you'll see the band and basket forms. And so the band forms, like right here, which does this have a pointer? Is it on the side? There we go. Maybe. Okay. So this one is this trophozoite is stretching across the diameter of the red cell. That's just something that the trophozoites do in Plasmodium malaria. And then they can also, as they're stretching, they can get these like cyst formation in that top left, and that gives us the classic basket form. I'll show in a minute. But here, once again, a microcyte, small, band form trophozoite stretching across, another band form stretching across, and these are all pictures from this patient. This patient had a pretty high parasite load, which is really cool. So we don't see malaria all that often. And here's a thicker band form that's still a trophozoite form. And then here's our classic basket that we see. So still a trophozoite, but it's forming that like little cyst inclusion. It looks like a little hand basket. That's classic for Plasmodium malaria. And then also this is another like a test question. But I was actually, I mean, I did see this in this patient, but I feel like we never see the merozoites forms in a lot of the different Plasmodium species. And so classically, Plasmodium malaria, does anyone know how many schizonts it has in there typically? You can count them. So this one's actually around 6 to 12, classically 8. There's 8 in this one. So these are all the schizonts. And then also just noting, this is like that classic malaria pigment that you can see. And then I did not find this in this patient sample, so I had to go to the CDC's lovely database of pictures. And this is the classic bird's eye. That's another buzzword for Plasmodium malaria. So in summary, so Plasmodium malaria is endemic in Cameroon. Classically, though, it's usually it's falciparum, but malaria is present there. And there is some resistance. So diagnosis is based off of microscopy, and then the antigen test is helpful to kind of, if you're on the fence, because this one, malaria can look a lot like falciparum if you miss the size of the red blood cells. And then buzzwords for the different forms of Plasmodium malaria. So the 1 microcytic red blood cells, the band and basket forms, the bird's eye, and then the schizonts with the 8 merozoites. Any questions? Okay, cool. There's a few references, and then, yeah. Oh, yeah.
We're gonna take a quick 5-minute intermission. So if you need to grab your food, go ahead. And I'll be right back. Okay. You ready? Orlando. That's why I was like 5 minutes because you walked away. I'm sorry. No, you're fine. So Luther is leading me. Nobody. Look at what the rice keeps me. Look at what they are. But I don't. No. Yeah. Okay. You might come. Man, I'm gonna present him first. So. Oh. Yeah. Introduce him. No. All right. All right. So now we're going to have Amanda present the next speaker.
All right, so it's my pleasure to introduce our next speaker, Orlando Soto Jimenez. He is a medical technologist with about 4 years of experience in clinical microbiology. Orlando currently works at UF Health here in Jacksonville, where he supports high complexity testing and some of the most challenging organisms we see in patient care. So we're very excited to have him sharing his work with us here at JAM tonight. Orlando will be presenting Caught in the Spiral, an unusual bug in an unfavorable timeline. So please join me in welcoming Orlando tonight.
Is it unmuted? Okay. Well, good evening, everyone. Like Amanda said, I'm Orlando. Thank you, by the way. I'm Orlando, and it's my pleasure to be presenting to all of you tonight a case that we recently had in the institution that I work at. And I decided to title it Caught in the Spiral. It was an unusual bug found in an unfavorable timeline, and we'll see. So let's set the scene. We have a winter morning. A 45-year-old male was found to be wandering and falling down in a gas station parking lot. When asked where he was, the patient responded that he's in a different city. Okay. There was noticeable pallor, very cold extremities. They could not get a temperature read at the moment. And the patient, of course, refused a rectal. So they also couldn't find any radial pulse. So he was taken to the ED. Okay. Upon admission, we have oxygen saturation around 80%, respirations 20 per minute, pulse 119, blood pressure plummeting down actively. So they decided to do a rainbow draw and start this patient empirically on vancomycin and pip/tazo. Okay. So day 1. Some of the key lab findings that we had upon admission: hematology, that CBC had a really high WBC count, almost 22, with 16% bands, which can, make us think that there's an active response from that immune system. When we go to chemistry, we have high sensitivity cardiac troponins, pretty high. Pro-BNP, super high, that heart failure there's definitely some heart failure in there. CK high as well, and that lactate is through the roof. In microbiology, what do we have? Blood cultures have been collected. They're in process. They're in our back text. Respiratory pathogen panel is negative. However, the MRSA screen was positive. Is there a reason why this is going like mute and mute? Okay. Sorry. So continuation of day 1 and day 2, we have an altered mental status. The patient became aggressive and combative, which made his hypoxia worsen. And the team decided to intubate him, which required a heavy sedation. And they decided to perform some CT scans and some more labs while our patient was taking a nap. So what did they find? On the head CT, they saw moderate loss of cerebral volume, as well as ventriculomegaly, which could explain the altered mental state. On the chest CT, they actually had a concern for a pulmonary embolism, and they ruled it out with the chest CT. However, they did find opacities and nodules, so now they're like, does our patient have pneumonia? Microbiology update. His HIV screen came back positive, and his Genius came back positive as well for HIV-1. Antibody, CD4, 10. Okay, I don't know. We're dealing with something different now, possibly. So day 3, it hit the fan, okay? So our patient's hypoxia worsened. Improved. So they actually decided to extubate him. Regain consciousness, of course, and he was cooperative. He was providing more PMH, past medical history. And among all the things that he mentioned, he said that he had stomach cancer and was being treated with radiation. That was it. Nothing else. No place, not when. No, that was it. So care team was like, okay, let's give him his new diagnosis and care plan. The patient once again became highly agitated, combative, and verbally abusive. If I'm not mistaken, he actually attacked someone physically. And still, the care team was trying to counsel the patient, like to keep him there because he actually needed that. However, the patient decided to leave our institution against medical advice. And that's where, you know, the story ends for hematology, chemistry, coagulation, blood bank. However, that night, microbiology had a positive blood culture, aerobic bottle, day 3. Okay. This gentleman over here had it. On 10, you can't see it over there, but it's 10x. You know, we're screening like we always do. We screen at 10x. Nothing. We don't see anything on 100. Okay. What's up? What's happening here? Who's that? Okay. And once we saw that first one, you know, it was everywhere. It was everywhere in that smear. That's what we saw. That's what the organism saw. Okay. Because we were like, okay. So we're dealing with faint. Actually, they're very faint. I edited these pictures because you could barely see them on that gram stain. Okay, we made another gram stain. No, it just didn't hold that stain. So we're dealing with faint staining, curved gram-negative rods with a subtle spiral morphology. We can't really tell if it's an actual spirochete or if it's a curved gram-negative rod. And like I mentioned, the visualization in the smear was very difficult. But once you caught that first one, you know, you were like biased, you know, it's everywhere. So at the microlab, like we always do, we have a gram-negative rod. We played at BAP in McConkey at 35 under 5% CO2 atmosphere. There was a gram-negative panel set up on this. Of course, no targets detected. So now we're like, okay, you know, it could be one of the targets, but we're possibly dealing with something entirely different and something not routine that it's not an E. coli, it's not a Kleb, it's not a Proteus, it's not, you know. So what are we possibly dealing with? Anyone have an idea? Okay. Anyone else? Syphilis? Okay. Okay. Leptospira? Okay. Anyone else? These are wonderful answers, by the way. I love it. Oh, sorry, what was that? Actually, no.
Who was the correct answer thrown out?
Yeah. So on, you know, it could be a lot of things. It could be Leptospira, it could be Borrelia, it could be, I don't know, something that we haven't even seen before. But on day 4, the patient had left against medical advice. Our patient was brought back again to the ED. Different shift, different time. People at the moment didn't recognize him, so he was admitted as a John Doe. Again, hypothermic. They couldn't get any temperature read on him, only by esophageal probe, and it was 80 degrees. Patient was unresponsive. He was also found they were like, okay, now we know what it is. Let's plate it so we can recover it. Wonderful. Okay. So they plated it on BCYE, BHI, and some Brucella media microaerophilically at 35 degrees. We were plating microaerophilically at 42 for Campy. So we pivoted. So we plated it on BHI microaerophilically at 35 instead of 42. Fine. So on day 7, we finally have a partial recovery. The plates still have no growth. However, that BHI that we did yesterday, it has scant growth after being plated under those conditions. So we were like, let's set it up on the MALDI. So the MALDI gave us that result, an unvalidated Helicobacter cineati with 1.98 confidence level. You know, high genus confidence level, pretty close to species. But yeah, it could have also been because the plate was maybe a little young and we were already on day 7, you know? We were like, what is this? So when we're reporting, we go back to the charts and we realize that the care team had decided to take the patient off of ECMO. He went shortly after into cardiac arrest and expired. Okay, 45 years old. So let's do a short overview of this bug. Sorry. So we have Helicobacter cineati. It's considered an enterohepatic organism, and it's capable of translocating from the gut into the bloodstream. It was previously classified as a Campylobacter until genomics came along and we realized it's actually a Helicobacter. It's not a Campylobacter. It requires special conditions, microaerophilic environment, and time, which a lot of times we don't have. It's thin, it spreads out, and it looks like it's swarming on the plate. So sometimes, all of you have seen the swarming of, let's say, Clostridium septicum or something like that. You know that it looks like a lawn, and sometimes if you're not trained on that, you could think there's nothing there. So it grows like that. It can cover the whole plate, and you don't see like a convex colony or any irregular. It eats the whole plate. Commercial systems as well as traditional biochemicals are unreliable to ID this organism, and it's unfortunately not included at the moment in either Bruker's or Bitech's FDA-approved databases on the MALDI. So basically, our best option we have right now, it's PCR16S sequencing. And because of that reason, it's an organism that's it's easily missed, and literature thinks that it's very underdiagnosed because of that reason. So some takeaways from this case. We're all pretty familiar with, no growth doesn't mean that it's negative. It could mean that it needs some adjustment in the conditions that we're plating it at, as well as the gram stain morphology. It matters a lot because we did treat it as a regular gram-negative rod, but we knew that it was something possibly outside of what we normally deal with. So it did guide us down a different action algorithm at some point. When all else fails, go beyond. Literature, I don't think anyone here likes to actually read papers and sit down and process textbooks and stuff, but sometimes, thank you. But sometimes you have to do it, Sometimes the answer is in there and we just have to look for it. And clinical context is everything. Does the patient have any gastrointestinal past medical history, or are they immunocompromised, This is a plate, by the way, of Helicobacter. I don't know if you can see over there, like the swarming it takes on the plate. And these are my references. Also, fun fact about this Helicobacter, not that fun. I just thought it was very interesting. I am very into etymology and like where names come from and why do we name it like that. Helicobacter, helical bacteria. But Cnidae actually comes from Cnidus, which is a Greek term. It's basically a derogatory term for men who have sex with men. So this organism was first identified in the 80s, specifically in that demographic, causing proctitis and related symptoms. And because of that, they decided to name it like that. And when I first looked it up, I was like, this has to be a joke. And no, I actually found a paper where they were like, it was first found here, we named it like this because of this. I was like, oh, okay. And that really says more about micro back in the day than the organism, but I just thought that was interesting and should share it with you guys. But yeah, that has been my case. Any questions? So they were trying to contact the family, of course, because it was a John Doe. They were doing everything to contact whoever was close to this person. And they eventually, I don't know exactly how they found out, but the patient was being looked for in another county because of his HIV status. And I don't know if he knew it at the moment, but they were actively looking for him. And our county came in contact with this county and they were like, okay, so yeah, we have the same person. At least that's what I found.
The first time we went through, he didn't ever get to John Doe to maybe think, like, I'm asking, like,
Yeah.
did the physician John Doe through your patient with all of this information, or did they not know that and therefore maybe didn't make the best decisions they should have?
If they did, it happened after he passed. Yeah.
That is our downtime.
So, I mean,
I'm not
they,
suggesting that
yeah.
Farrah should get involved, but.
Yeah.
Problem is that the whole time he's sitting in the hospital, if they had known that this person had all of these issues, whether they could have done anything versus which to connect the dots. And I don't know how you're supposed to do that, which is have to have a name on it.
Exactly. My opinion is 100%. This case has like missing things all over the place. I'm pretty sure they identified him after he passed away, or someone came back and they were like, okay, yeah, this is our patient that we had 2 days ago,
Whether or not hospital or otherwise, but.
Yeah. Thank you for that, actually, because I wanted to add, and I almost forgot, that this organism has not a wonderful, but has a very good prognosis. Okay, if the patient probably was compliant with the treatment and he had stayed the first time in the hospital, he was probably still be alive. However, he was empirically started on some antibiotics. It didn't target the Helicobacter, at least not entirely. It's not the recommended treatment for that organism. So basically, the care team was completely blind at least in the microsection. No. Yeah. Another thing that happened was that when we were gonna report, the organism, we saw that there were 2 charts merged. And when we went to the other one, that's the one where he had passed, because he had been admitted as a John Doe. So, that's like a new chart, So when we clicked them together and we put all the story together, that's the timeline, it wasn't even a day where he left AMA, the blood culture went positive, and he came back. And the blood culture went positive in that time that he was out, you know? So it's just, that's why I said an unusual bug in an unfavorable timeline, because it could have been managed way better. Unfortunately, that was not the case here. But still, this was our first Helicobacter in, I think, ever, probably, isolated. So that was our, at least in the 4 years that I've been here, we had never seen that. So that was like, okay, bad for the patient, but really cool that we actually isolated one, you know? And if it wasn't because they didn't cheat, but if they hadn't done that molecular ID, they also would have been blind in all that workup. So thanks for them that they share that knowledge as well, because otherwise we would have been completely blind. Also, the guy who saw it was this guy over here, Alejandro. So thank you for that. Yeah, when we came that morning in and he had that for us, we were like, I don't know.
I mean, like, who wants to see this?
We were. It's probably a campy, but yeah, it was not campy.
Who wants to look at this and tell me I was
It used to be one, but yeah. But thank you. Any other questions? Okay. Thank you.
I'm gonna invite Dr. Hada to present our next speaker.
right.
Diana.
Okay, case number 3 for you tonight. This should be pretty good. I have the pleasure of introducing our next speaker, Diana Meza. She is currently an assistant professor at Mayo, and she's been working in the microbiology laboratory for 20 years as a subject matter expert in mycology, mycobacteriology, and parasitology, including bloodborne pathogens. So an all-around player, if you will. Diana has a master's degree in microbiology from Pontificia Universidad Javeriana, sorry about that pronunciation, in Colombia, South America, and is certified by ASCP as a specialist in microbiology and as a medical laboratory scientist. Diana is incredibly dedicated. She's got a wonderful, strong background in her field, teaching medical laboratory students, infectious disease fellows, and other medical observers. And in addition to all of that, she is she's participated in academic initiatives in Colombia and has been teaching mycology at the master's level. And I've had the privilege of working with Diana for a long time now, I guess. And it's been incredibly productive and very educational. So please welcome Diana Meza.
Okay, yes, you had me. Thank you very much for the introduction, Dr. Hara. And yes, in my 20 years at Mayo, I'm so happy, but very grateful because that cannot be possible with Dr. MacArthur. I don't see her today. And Noel Gomez gave me the opportunity when I moved to Jacksonville. So I'm very grateful with them. Okay, I want to start with my case. So this is a female patient, 69 years old, consulted during 2016 for palpitations. In May 2017, she was evaluated by cardiologists, and that evaluation was in another hospital. They put a pacemaker in July 10, and after that, she was with some infection. In August 3rd, she was referred to the cardiology. cardiologist. In August 4th, 2017, she was admitted at Mayo Clinic. So she didn't present fevers, diarrhea, dysuria. So past medical history, including diverticulitis, cholecystectomy, hysterectomy, and some allergies to codeine and some medication she took at that time. Social history, no smoker, no gardening, no pets, family history, hypertension, dementia, nothing else relevant. And the physical exam, it was pretty normal. Just only the erythema in the site where she had the pacemaker. Next, please. Only the hemoglobin shows low, 9.4, and the CRP was high, 137. No other critical labs. So at Mayo, in August, they decide to remove the pacemaker, cultures of the deep pocket tissues and the pacemaker and leads were sent out to the lab. And they put a temporary pacemaker, started with vancomycin and cefepime, and consult with ID infectious disease. The specimens were collected, and they ordered only gram stains and miscellaneous culture, no fungal cultures. So we found Aspergillus secondary to surgical contamination. So when we got the specimen arrived, we did a gram stain, and there you can see the branching septal hyphae and branching in 45 angle, which is very typical of Aspergillus, can produce in other filamentous fungi, but this is a typical presentation of Aspergillus. And day three, the cultures came back, blood culture, no growth. And because they ordered for miscellaneous culture, and we saw in blood plate, chocolate, McConkey, I was working that weekend, and initially I thought it was a contamination. But when I back to the gram stain and review, and it was very septal hyphae, because Aspergillus can be contaminant or can be colonizer or environmental. So I was very careful, and I wrapped the plates. Then I soak on Savuro, and very typical blue-green powdery colonies, which they grow very fast. And on the lactophenol blue, it's very typical to see in our lab. We can identify and speciate most of the Aspergillus are very common. And for Aspergillus fumigatus, it's hard to see here, but it's very distinctive. Uniseriate phyalides just shows only one row of phyalides, which is helpful. In the conidia, the phyalides cover only half of head of the vesicle. So having the macroscopic, so blue-green colonies, now with the lactophenol, we can conclude is Aspergillus fumigatus complex. So other tests they ordered was Aspergillus antigen, but it was less than 0.5. And on the left side of the thoracentesis, they found a Staphylococcus coagulase negative, one colony. And they implant the new pacemaker after 2 weeks, having the patient on voriconazole. The temporary leads, I already said they were removed, and the patient improved with discharging after following day. So general risk factors to get Aspergillus fumigatus complex, because it's very rare to have infections for Aspergillus. So it might be related with the malfunction of ventilation or some environmental contamination, or in experiment physician, or there are bed droppings near to the windows or the vents, but it was very unfortunately the patient got that kind of infection. Patients under immunosuppression or long-term on antibiotics or steroids are very risky to get that kind of infections. Most of the organisms involved on pacemaker infections include 60 to 80% the Staphylococcus aureus, and some other part Staphylococcus coagulans negative, and E. coli and other gram negatives occupy another percentage. But fungal infections is very rare. It's only 1 and 2%. And Aspergillus is the most common found, which can be very dangerous and can cause complicated endocarditis. So the symptoms include fever, changing cardiac murmurs, heart failure, sepsis. And the first election for the treatment is voriconazole, and of course, remove the pacemaker and debridement. Another antifungals they can use is amphotericin B, itraconazole, and flucytosine. Well, and the diagnostics in the laboratory we receive in other specimens, and we see very frequently, because in our hospital we have a lot of immunocompromised patients, and so it's very frequently found in BAL, even in sputum. In sputum, we are more careful to report because can be colonizer, can be environmental, but specimens like BAL always we report tissues, other biopsies. And again, to see on the gram stain or on the calcofluor, seeing this branching 45 angle is very typical of Aspergillus. Next. And just to remind how to recognize, differentiate Aspergillus fumigatus from other Aspergillus. The color of the colony is very helpful. So blue-green colony is more possible to be Aspergillus fumigatus. However, there are another Aspergillus like Aspergillus clavatus, shows that kind of color. And under microscope, always we will find a vesicle and the phyalides. And most of the Aspergillus present biseriate phyalides, meaning 2 rows of phyalides, except Aspergillus flavus, Aspergillus fumigatus, Aspergillus clavatus, and that's most the Aspergillus shows uniseriate phyalides. So it's very helpful to look if the phyalides cover all head, just only one head, one half of head or half of the vesicle, so that helps. And how is the arrangement of the conidia? Because, for example, in fumigatus, the conidias are going in chains. Same happens like in Aspergillus flavus, but the color is different. Culture continue to be the gold standard, and we inoculate specimens for fungal cultures. We use BHI, Saburo, and IMA. And growth very fast at 2-3 days. We got the growth, and again, visualize and recognize how the color macroscopically and what the structures we can see. Other tests the doctors take an order is the Aspergillus platelia antigen. But that test is good for invasive aspergillosis, but that test needs to be run 2 specimens in a row, and the cutoff is 0.5, so needs to be greater than 0.5 and 2 specimens in a row, and they show a lot of false positives, especially when the patient are in other antibiotics like piperacillin, tazobactam. And if the patient ate pasta or rice, so it can show some, or if the patient has another infection for another kind of penicillium or other filamentous fungi. I think that's the most important. And just in summary, the Aspergillus is a mold can be found in indoor and outdoor. There are many species or subspecies of Aspergillus species complex. And they can cause allergic reaction, aspergilloma, disseminated. And like the risk factors include the immunosuppression. And I want to share this beautiful picture I got in one of my courses in Netherlands in 2016, showing the uniseriated lines of the Aspergillus. I don't know if you have any questions or any comments. Yes.
Important to speciate Aspergillus.
Yes, it's very important because most of the Aspergillus are sensitive to amphotericin B in terms of talking about invasive aspergillosis. And now some Aspergillus like Pteros and Phlebus complex comes more resistant. The election for Aspergillus is voriconazole in invasive aspergillosis, but there are some cases of resistance too. I want to add this comment it was a very good learning, very educational case because the doctor ordered only miscellaneous culture, and we were lucky to find on blood plate because it grows in non-selective medium and grows very fast. But think about if the filamentous fungi was probably another mold or black mold that takes 2 weeks to grow, that we cannot identify. So I think after that, the residents or the doctors always stay, even for this kind of device, which the most significant is the bacteria causing infection. Now they always order fungus culture.
Is miscellaneous just aerobic, anaerobic?
Aerobic and anaerobic, yes. And we saw on blood, chocolate, McConkey, and CNA, and thione. Yes. Okay, so another question? No, thank you very much for the opportunity.
Thank you so much. All right. Oh. And now, last but not least, are you okay? You okay? Okay. We are gonna have Marta Rivera Schettini present our last speaker of the night.
Thank you. I don't need to press anything?
No, no.
No, okay. Hello. I just want to say first, thank you for always letting us crash the party. We love this and we love this community, so thank you so much. We'll keep crashing the party every year. So our next speaker is Dr. Claudia Patricia Marquez. Dr. Claudia Patricia Marquez, she's gonna hate me for this first. She earned her PhD in quantitative biology and molecular genetics at the University of Texas at Arlington, where she studied the genome evolution of Trichomonas vaginalis. And the people who knows her, that's why she has her trick tattoo. Claudia has been at Roche for 7 years and is a medical scientific liaison in the molecular lab and infectious disease team. Claudia is passionate about promoting positive sexual health education, advocating for minority patients, and ensuring equal diagnostics and medical access for all population. And I'm lucky to have her as a colleague and a friend. Welcome, Claudia.
Really long. Okay, so I know I'm between like more beer and more food. So this is going to be very, very informal. It's just basically just telling the story of why it's so important that you all can run all these different tests and identify the organism, because that's ultimately going to change a patient's life for the better, hopefully, if we can get those diagnoses in quickly. So just super quick, I am an employee of Roche Diagnostics, but I am on the medical and scientific affairs side. So I get to do all the fun stuff that does not include selling. So I get to do all the education, I get to do all the weird sample types, weird LDTs, all of that fun stuff. So not saying that like other stuff isn't fun, but for me, this is funner. Okay, so there's a lot of information on here. Basically, we're just really going to cover why it's very important that we have access to laboratories and that our laboratorians actually think outside the box and think about all these crazy things that could possibly happen, again, because it goes back to, our patients. So Martha said, I'm very, very passionate about folks talking about, sexual health and stuff. And when we thought about sexual health, and something that we're trying to change is that we thought about whether the presence or absence of disease. That's the only way we thought about sexual health, right? So we're trying to change that, because it's really not just about like the presence or absence of an infection or a disease. It's like a whole body thing, right? So we know now that sexual health like plays a massive role in people's happiness, and also in like we've learned about consent and a lot of different things. So when we talk about sexual health, basically from this slide, take home, it's not just about presence or absence of infection or disease. Like there's a whole other organism that's part of that sexual health space, right? And why we have to, like, it's really important that we screen for all these infections, because a lot of them are asymptomatic. So we don't talk about it as much, but the STI epidemic still remains a big public health challenge. You guys see it firsthand, right, in your labs and all of that stuff. But in the cases of congenital syphilis, which it made me kind of giggle, because there was an article that came out last week that was like, syphilis is back, blah, blah. And I'm like, honey, it's been here. Like these cases of syphilis, like, I don't know where they got the memo, but I'm just like, it's been this bad forever. So, yeah, you guys know, bless their hearts. But yeah, I mean, just in 2020, right, to now, it's like 42 to 82% in congenital syphilis. Like, it's just insane, these numbers. So that article just made me giggle in like a sad way, like, oh no, we're not paying attention. But and then you can think about all these, direct medical costs. Here I'm just talking about chlamydia, gonorrhea, and syphilis. These are all treatable and preventable infections, and they're all things that we have hopefully access to screening and testing for. right? So when we talk about these guys, these are the ones that are reportable. Like you had that patient that they were, you know, they were living with HIV, so somebody was trying to track them down. It's the same thing with these guys too, but there's also other reproductive tract infections that contribute significantly to the disease burden. But these are guys that aren't tracked, or they're not you know, sent to like our public health departments or anything like that, right? So nobody is keeping track of these. But you guys know I had to show Trick on there. So yes, I do have a trichomonas tattoo. She is my baby. I love her, and nobody can change my mind about it. It's the coolest bug ever. But you know, trichomonas, it's the highest non-viral STI actually that infects most women and most men too. They just happen to be asymptomatic. Mycoplasma genitalium is another one that we don't talk about a lot. And it's one of those things like which came first, the chicken or the egg? Is there not a lot of Mycoplasma genitalium because we're not testing or screening for it? Or is it just because it's not prevalent? So there's a lot of research and stuff going into that as well. Another thing we don't think about because we don't consider them being sexually transmitted infections, but bacterial vaginosis and yeast infections in women, right? So those also have a huge economic impact. If you've ever had one of these infections, they are a pain. Sometimes they're very, very hard to treat. So again, it's really important that we can identify all of these organisms because we need to diagnose that patient correctly, right? So just super quick, the difference between screening and testing, that's always like and Andrew, you know this, like that's always a point of contention sometimes where it's like, well, are we testing an individual or are we screening? So when we're screening individuals, when we talk about sexual health, we are identifying individuals that are at risk of contracting any sort of infection. Now, if you are sexually active and you are having any sort of non-barrier method sex, you are at risk of contracting a sexually transmitted infection. It just is what it is, right? And when we talk about, when we talk about testing and stuff, so with testing is we're trying to determine if an individual is infected. If you've ever had a BV or CV infection, you know that just taking antibiotics could actually cause that infection. There doesn't have to be any sexual contact. So that's another thing where we want to get rid of that stigma, right? So I don't like to use the word high risk or any of that because literally if you're having any sort of non-barrier method sex, you can be infected, whether your partner, it's one partner or 50 partners, it can happen to anybody, right? So again, the screening is usually driven by risk factors and population. To me, it's like if I'm going to talk to a patient and I just ask, have you been sexually active without a barrier method, whether that be oral, anal, or genital? Yes, I don't need to know the partners. I don't need to know anything. We're going to screen you, period, end of story. So that's something that we really work on, like in the sexual health community, where we're trying to get clinicians to just, that's all they have to ask. They don't have to ask anything else. And one example is obviously screening our pregnant individuals for STIs and syphilis, because apparently that's a new thing now. And then testing if an individual is infected. Most of these folks are going to be symptomatic individuals or with known exposure. So basically I could say, hey, I had unprotected sex 3 weeks ago. I've got some weird symptoms going on, or I don't have any symptoms yet, but I have a feeling there was some sort of exposure here. Let's go ahead and get tested. Okay. All right. So there's a lot of information on here. This is the current guidance for STI screening. And the reason why I have this out here and the reason why I wanted to talk to you guys about this was because you see chlamydia, gonorrhea, those guys are bacteria. Trick is a protist. So Trichomonas vaginalis is a protist. Mycoplasma genitalium has, that's another bacteria. BV/CV, we've got bacteria and fungus, syphilis, herpes, yada, yada, yada. We're getting into the viruses now. All of these guys need to be identified correctly in order for the clinical actionability for those patients, right? And that's not going to happen unless the lab can do that, right? Unless you guys have the testing available for it and all of that stuff. So this is just the preferred sample types. This is sometimes where I get a little annoyed because you'll see that a lot of these are approved for urine, or for individuals with a vagina, the vaginal swab is better. And what I've heard is that because the urethral swab can be uncomfortable, that's why we have urine. So we'll just leave it at that. Just leave it at that. So yeah, but you'll see, you know, there's a lot of different testing and stuff. And again, going back to this is our, you know, individuals with a penis or anybody that has a symptom of urethritis. Again, what you want to do is make sure that you identify whether it's a bacterial infection, or in this case, it could also be trick, which is going to, do you like my drawing? Yay. Which it's okay. I have women too. So, you know, here we're identifying, is it bacterial or is it a protist infection? Cervicitis, same thing. So now we're actually going to look into, is this chlamydia, gonorrhea, or trick, or BV, which is going to require different treatment as well. Or, you know, syphilis, MG. Again, all of the testing that you guys are doing in the lab are literally to drive the patient clinical actionability. Okay. And then here's one that we've just, it's not new, but we are covering more and more. So if a patient comes in with vaginitis or vaginal discharge, which is a very kind of common, you know, symptom that you can have, what you need to do again is identify whether that's bacterial as far as chlamydia, gonorrhea goes, or a protist, trick, or bacterial vaginosis, or a fungal infection. Again, to make sure that we can get the, you know, and I keep talking about what the lab does and all of this stuff. Basically, you guys are going to be the ones that are going to help us bring these numbers down, because the more people are tested, the more people are identified, the more people we can get treated quickly. And another thing that I just wanted to add was, like, so currently the numbers say 1 in 5 people in the US have an STI, but that only covers syphilis, gonorrhea, chlamydia, and HPV. All right. So remember, we've got Trichomonas vaginalis, we've got Mycoplasma genitalium, we've got a whole bunch of other STIs that aren't reportable. So the numbers are probably estimated to be about 40 to 60% higher. So do the math. We're probably looking at about 3 in 5 folks that have an STI. Okay. Another thing about these STIs is that a lot of these folks are asymptomatic. So you can be carrying these forever, not have any symptoms. And, you know, yes, it's not bothering you, but if you are sexually active, you can pass on those infections to somebody else. Like we saw folks that can be immunocompromised or anything like that, right? So biggest thing that we've seen, and I know you guys have seen this, Dr. Hada, we've talked about this, Amanda, we've talked about this with Dr. McCarter, it's just like access to testing, right? So at your hospital systems, yes, you have these tests, they're available. I work with a lot of hospital systems that are more in like rural areas where, yes, they need to get the testing, but they can't get the testing that they need. Let's say they, you know, this patient is symptomatic, we've got them in the ED, let's get them tested, point of care testing, 20 minutes, 40 minutes, whatever. You know, it takes 2 to 3 days for the patient to get their results, and then we just can't find them, kind of with like the John Doe guy, you know what I mean? Like, so it's really important to get them tested. So here's the big take home message. Again, identifying these organisms, whatever it may be, Aspergillus or Campylobacter or whatever, all the other stuff we talked about today, is basically going to drive that treatment for that patient. You can tell, you can see here, if it's chlamydia, it's one antibiotic. Gonorrhea, another. MG, we kind of throw everything at it. The problem with MG right now with Mycoplasma genitalium is in population. So if you go to Alabama, wear a condom. In populations where the numbers are really, really high, the resistance rate of Mycoplasma genitalium is like up to 80%. All right. So Alabama, San Diego, California, Puerto Rico wasn't too bad. I'm selling a touristy thing. Those are 3 places where we had prevalence studies to see like what was happening. So yeah, Puerto Rico, not that bad. San Diego, yes. Alabama, yes. And the resistant rates in San Diego and Alabama were like 50 to 80%. So do with that what you will. Plan your next vacation, call me. I'll tell you everything you need to know. And then again, you know, when we're talking about our Candida or any sort of fungi, we want to make sure that we give the right antifungal. With Candida, we're actually finding now that we have some resistant strains. So there's some strains that are completely resistant to all azoles, so we've got to give them something else. And then there's some strains that are not necessarily resistant, but they're like dosage dependent. So you just have to have the patient on a longer treatment or just a higher dose. But again, all of this stuff we can't do without you guys like identifying all these bugs for us. So this was just talking about, again, the asymptomatic cases and all of that stuff. But what I really wanted to just take home for you guys is like, absolutely the lab, you know, the end of the day, like those tests are going to come to you all. You're going to have to identify them. Clinicians can't make the calls like you did without having that information, the identity of whatever bug it is that, and, you know, we don't think about STIs that much, but they're really, really important because they do cause a lot of infections. They can lead to like, you know, higher rate of acquisition for HIV, as well as like, we just have to be able to talk about this more and just, you know, reduce the stigma. So again, this is pretty much just what I wanted the take home to be, is just that, you know, we have to make sure STIs have overlapping symptoms. I'm sure you guys see this in micro all the time with non-STIs. So we just have to make sure that we can screen and diagnose those patients correctly, because that treatment is going to depend on it. The funding is going to depend on how many rates we can get down and all of that stuff. So that's my story. I'm sticking to it. If you guys want to talk about rates of STIs in different states, let me know. But yeah, that's it. So just thank you guys so much. And yeah, that's it. Yes, ma'am.
I know you, well, 2 parts. I know you talked about screening.
Yes.
And when you say screening, I know for women, you know, we get the whole, if we say we want an STI panel, we get everything, right? I think there's your platform as well. Like we get extended, we can get an
Yes.
extended one.
Yes.
But are clinicians starting to do that for men? Because it feels like most of the people who get diagnosed with STIs are women. So are the men now getting fully thoroughly screened, or there's the fresh? Hey.
You're going to get a face. Okay, so currently, men who have sex with women are not screened. Because, you know, we just get these out of nowhere. No, I'm just kidding. Okay, the thing is, according to the CDC and the NIH and all the funding that we have, like, we definitely need money for HIV. We definitely need money for syphilis. We got to keep track of chlamydia and gonorrhea. But what they did was, way back when, they identified the highest risk groups, and men who had sex with women were not included on there. So the people that get screened are any sexually active woman, men who have sex with men, like bisexual individuals, whether that be a man who has sex with women or a man who has sex with men, but if there's that interaction. And then like pregnant individuals, and then folks in prison. But even in prison, it's only the women that get screened. So yeah, so men do get screened for like hepatitis and stuff, but for like your big 3, your CTNGs, mycoplasma, TVs, it's just women. So there's a lot of work that needs to be done. There's a super awesome podcast. I'll send it to you guys that talks about just like the patriarchy and the history behind like that involvement and like sexual health testing, and how, like, you know, you guys see the stigma if a woman, you know, all of that stuff, right? So yeah, currently we're trying to push to increase screening. There's one of my friends did an awesome study down in New Orleans, Louisiana, where she actually screened young men for chlamydia, gonorrhea. Surprise, surprise, the rates in women went down. because she was like, they had this huge effort where they were screening young men. She was literally sitting outside bars and like offering them like a $20 Starbucks card and like a pea cup and was like, come on, let's do this, you know? And they were able to track like these infections that were getting these young women as well, because these were like high school aged folks. And the numbers went down. So Patty Kissinger, she's amazing. But yeah, so it's just trying to find the money, right? Where it comes from. And then like, okay, are we going to be screening everyone for trick, or do we want to catch this congenital syphilis? Like,
Right.
so yeah, it's tough. But yeah, give me a few more beers and we'll talk about about what I really think. No, just kidding. So yeah, get out there and get people tested. No. So we do have, yeah, we have, there's no approved test out there for screening for men. Even though we know that like 90% of pharyngeals, yeah, that's 16, 18, you know, nothing approved for men yet. So it would be like an off-label thing. Yes.
I'm not entirely convinced of this correctly.
No.
But, this Roche doesn't test, anal sources on men, right?
I mean, we do, but well, for chlamydia, gonorrhea, yes. Approved sample type, all of that fun stuff. For HPV, not yet.
How about TB?
TVMG, no.
That's why basically we can't do the 4.
You can still do the 4 tests. The problem is, and now there's a whole other thing we can get into, reimbursement.
I just thought it was an FDA clearing thing.
Yeah, a lot of it has to do with reimbursement. I know. Patriarchy and reimbursement. What else do you guys want? Just kidding. Thank you, guys.
That was awesome. Don't you guys agree? Another round of applause for all the speakers tonight, please. That was so good. All right. Thank you for everyone joining us virtually and in person. There are cupcakes in the back. I just don't want to forget. And then thank you again to Roche